Welcome to the Ketogenic Diet Show, and I am delighted to introduce you, Dr. Gurpreet. So I'd love for you to just give us a little bit of background, where you're practicing, why, and what you're up to in the community.
Sure. So my name is Gurpreet Padda. I'm a medical physician. I practice in the urban core of St. Louis. I practice interventional pain. So I'm in a unique position to see patients that have extraordinary issues with severe, unrelenting pain in an urban setting and trying to figure out how to improve their lives. And I'm in a time period in our history of US medicine in which we have the confluence of an opiate epidemic impacted by a nutritional epidemic and a diabetes epidemic. And I've found over some period of time that all of these things are interrelated. This is all intertwined mess. And so I've been trying to untangle this for my patients.
Fantastic. Me too. So I so appreciate you being a mouthpiece for what the universe needs right now. And tell us a little bit about the interconnectedness of what you're doing. You mentioned that these are all intertwined, and I agree, and I'd love to hear your perspective on that.
Okay. Well, how I approach it, I work with a lot of groups. I just spoke at Exoneration Nation last week, and it dealt with prisoners that were released because they were improperly imprisoned. And they were improperly imprisoned. Many of them had been there for 35 years. They were serving life sentences, and they were finally released because they were convicted improperly. I'm dealing with people that have very, very serious issues. I grew up in India, but moved to the US when I was about 9, and I lived in the urban core. So I firsthand have seen what's been going on. And what's going on is that we have people from a very young age who are unable to complete school. They're unable to function in school. They have tremendous ADD. They have tremendous dysfunction with the things that they want to do on a day-to-day basis. And that dysfunction prevents them from educational achievement. And with a lack of educational achievement, they get frustrated and they enter the criminal justice system. When they enter the criminal justice system, it's a one-way ticket, because a lot of times they get disenfranchised and they can no longer vote. And if they can no longer vote, their community suffers. So if you back up one step, what happens? If you look at 5-year-old African-American kids, they're incredibly intelligent. They have the same IQs as 5-year-old Caucasian kids in the same environment. But over time, the 5-year-old African-American kids become 8 and 10-year-old African-American kids, and their IQ is a little bit different, and their ADD is a little bit worse. And so that it prompted me to research that. If I told you that we had a disease and it was coming and I could see it and it was going to affect 75% of the United States, if 75% of the United States was about to hit an epidemic, and that epidemic was going to take 2/3 of us and make us terminally ill, and it was going to threaten our very existence as a nation, and it was going to be the single most expensive disease in our history, you would pay attention. That disease is here. In 2025, 100%, 99.7% of the African American female population will be overweight or obese. In 2025, that's 5 years from now. If that happens, which it will, 2/3 of those will go on to have diabetes. Half of those will go on to have end-stage renal disease and will be on dialysis. The cost of care per patient on renal dialysis is over $100,000 a year if you look at their disability and renal dialysis. That's ridiculous. I did an epidemiologic study in St. Louis because that's where I'm from. And I found out that in an 8 square block area by 2030, the entire state budget for the state of Missouri would be spent in 8 square blocks because of the cost of end-stage renal disease. So if you can imagine extrapolating that out to the rest of the country, and it's not an urban core problem, it's actually worse in the rural. It's worse in the rural areas. And so, we have this epidemic coming. It's called diabetes. It's called obesity, and it's dietary.
Yeah.
And we can change it. And I change it every day. I have patients that literally come to me that weigh 450 pounds, and 2 years later, they've lost 180 pounds and they're no longer diabetic. And we change this at a root level every single day. And I started in the pain side because those are the patients I saw first.
So, can you speak a little bit to? I have a lot of questions for you, but I'd love for you
Sure.
to speak to the types of pain that you're dealing with. Is there a
Yeah.
theme or a genre that you're seeing most consistently?
Well, what we see is polyarthralgias, which is multiple joint pain.
Yeah.
So there's a beautiful study that had to be retracted. The study was excellent, but it was retracted. The reason why it was retracted was that they didn't get enough informed consent. And I'll tell you what the study was, and then you'll understand why I still think it's a valid study. What they did was they looked at patients who were diagnosed with fibromyalgia, diffuse myalgia pain, diffuse joint and tendon pain over their entire body. And they looked at these patients and they looked at their hemoglobin A1Cs and their insulin resistance ratios. They looked at their LPIR scores. And they found out that the vast majority, over 95% of them, were pre diabetic. And if they treated them with metformin, 2/3 of them no longer had joint pain in 6 months, no longer had tendon pain in 6 months. Now, that doesn't mean that these patients didn't have fibromyalgia. Fibromyalgia is a symptom diagnosis. What it means is fibromyalgia is precipitated by a pre-diabetic state.
Mhm.
And so if you look at it closer, if you look at it deeper, you find out that they have severe metabolic inflammation or something called meta-inflammation.
Mhm.
And if you look at it even deeper, you find out that their omega-6 to omega-3 ratios are wrong. And so they have way too much vegetable oil, not enough omega-3, and they have a high glycemic index and a high glycemic load constantly, and they're pre-diabetic.
Mhm.
And so the reason why the study was retracted is that they didn't give them enough consent to say, well, we can publish this information. They gave them consent, but they didn't get the publication consent right. So they're redoing the study. The study was a retrospective study, and it should have been done prospectively.
Mhm.
But the end result was the patients got better, and they figured out the right answer. The study will be repeated. The results, other people have done something similar. The results will be very similar, and I see it in my clinic every day.
Yeah, me too. Our
Yeah.
same thing across the board. Omega sixes and threes are so out of balance, and so many people have not only chronic pain but chronic fatigue as a result of it. And it's the uh,
Same thing.
same thing.
It's the root cause of 75% of our medical costs in the United States comes down to three factors. It comes down to vegetable oil.
Yep.
It comes down to too much sugar over too long of a period of time. And it comes down to other things that cause leaky gut. And the most common, unfortunately, is gluten or gliadin. If you took care of those three problems, we would eliminate 75% of the disease process that we have. Um, and I take patients every day that are on 60 to 100, 120 units of insulin a day, and I drop them. And within a month and a half, they're off their insulin. And within 6 months, most of them have hemoglobin A1Cs less than 6.5. My target range for hemoglobin A1C is below 5.5,
Mhm.
even though 5.6 to 5.7 to 6.5 is considered pre-diabetic. I want to get them below that.
Absolutely.
Um, and so I'm pretty aggressive about getting not just to a low carb diet. I'm aggressive to getting them to a zero carb diet. No carbs.
Mhm.
And so when we do their cleanse protocol, when we start out with them, we're really pretty aggressive about getting them to no refined carbs. And a lot of times for the first 6 weeks, we're not even giving them unrefined carbs. We're not even giving them vegetables. We're giving them basically meat, eggs, butter, water, and salt.
Yeah.
And so we have an anti-inflammatory induction phase.
Wonder.
Um, and it works really well. So let's let's talk about a little bit about the community and how we know that this is an intentional thing that our big food companies are doing.
Mm.
Um, we talk about sugar sweetened beverages all the time. I have to talk to my patients about sugar sweetened beverages. And they tell me, well, it's a soda. It's just one soda. And if it was just a soda, it would be one thing. But what our sodas have is we have high fructose corn syrup, which is 55% ratio of fructose, 45% ratio of glucose. Um, but that's not what we actually have. That's what's listed on the package.
Mm.
What they've done is they've manipulated high fructose corn syrup even further and artificially spent more money to increase the amount of fructose to a ratio of 60-40, which costs them more money. And you might want to ask yourself, a company that's trying to make money, why would they spend extra money to make it a high fructose corn syrup? Because you don't have to put that on the label. So why would they spend money to make it a super high fructose? And it's real simple.
Mm.
And this is why we get into the addiction part of this now. Glucose causes a serotonin release and causes you a general wellness feeling. It's satiety, feels generally okay, but it doesn't cause very much dopamine release. Fructose, however, causes a dramatic dopamine spike, almost in real time. And the higher your fructose is, when it's out of balance with your glucose, your ratio is so high of dopamine that you begin to immediately crave that. And so that's why they've manipulated our high fructose corn syrup to super high fructose corn syrup, so that every time you have a soda, you're more likely to go drink another one. The whole point of the big food companies is to get you to buy more. And they send out these marketing messages that get embedded in the heads of my patients, like breakfast is the best meal of the day. It's the best meal of the day if you're a cereal company, because it's going to make you eat every 2 hours. And so what we're trying to do is to re-educate these patients and get them away from these mass media marketing systems, and try to make a difference for them. And a lot of time that I have to spend is on re-education. It's to break down those issues and re-educate.
Absolutely. Yeah, that's what takes so much time. And not only do most doctors not understand what needs to be done, but they certainly don't have the time to do that sort of educational process that it's going to take to really help people relearn a whole new way of living that doesn't involve, listening to the media and that sort of thing. So I really honor the fact that you're taking time to educate your communities and people to eat differently and yeah, try to reverse this, because you and I both, I would agree that diabetes is completely reversible. And it sounds like we have a similar tactic in terms of how to do that. And I'd love to hear a little bit more about what, I mean, we could go on and on about what the problems are. There's so many intertwined issues with pharmaceutical companies and food companies at this point that I don't know that there's any way to dismantle that, but we can definitely focus on the solution. And that's something that I want to just open up that conversation with you a little bit about what we can do as practitioners.
So what I did was, I have a hard protocol that I use that I share with my patients, and it's available on our website. We don't charge anything for this.
Mhm.
I do about $1.5 million of free healthcare a year, specifically targeting this area. So I don't charge for what I'm doing when I'm treating this area. I make money on my interventional pain side, but on my side where I'm trying to change people's lives, and get their diabetes reversed, we don't charge. And so we have a protocol that we share, and we share it openly and freely. It's exactly what we talked about. We have a bunch of videos.
Mhm.
We have protocol. It's on our website. The What I do is I educate, and my theory is this: people learn by repetition. And so what I try to do is I try to find the commonality. I try to go to the African American churches and to the Baptist churches and to the other churches and interact with them there. And I try to find their key opinion leaders and get them to change. And I change them because most of them are diabetic, most of them are overweight. And I start to change them, and it creates a ripple.
Mhm.
And so every time you throw a rock into the pond, you're creating a ripple. When those ripples hit each other, it causes a summation wave. And so you start to change community. So we have 65,000 active patients in our 11 clinics. And what we've done is we have patients leading educational groups. We have patients helping patients, helping patients, helping patients. And so what's happened is I sometimes come to clinic and I find that my hallway is filled with 25 people who are having a group meeting using our chairs in our hallway because they're having a support meeting that has nothing to do with us, where they're not even coming to see me. They're not seeing our clinic, but they're using our common area to have a group meeting and sharing information. And that started about a year and a half ago. I noticed a strange pattern where people were showing up early, an hour before their appointment, but they weren't there to see me. They were seeing each other, or they were there to see something else, and they just happened to swing by. And I'd look out there, and there would literally be 25 people sitting around sharing their experience and sharing recipes and sharing concepts. And so what we do is we created a hard protocol. This is what you got to do. You follow this protocol, we know it works. And then if we need to medically manage you, that's where I come in and I help you reduce we help you get your glyphosate off. We help you get your insulin down. We manage your potassium. We manage your sodium. We make sure you don't go into atrial fib. We check your ultrasound of your liver, make sure you're not going to have a gallstone attack. So we're medically managing you over here, but the diet you're going to manage.
Yeah.
And we're going to tell you how to do it. And I find that reinforcement by their peers in their social group is what's made the biggest difference. And it keeps me from having to repeat myself.
Absolutely. That's such a beautiful model. I just really, really appreciate you sharing that. I think that is so important, and it's so to the core of what we all need to be considering when we look at change, any kind of change. And so, thank you so much for painting that picture. What a beautiful model! I
Yeah.
love it.
And so that also brings you to what addiction is. So I told you that addiction is dopaminergic.
Mm-hmm.
That's part of it. But there's a rat study that was done. There's a beautiful rat study. What they did was they took rats, they put them in a cage, and they gave them an opportunity to either have plain water or water with cocaine in it. And the rats picked the cocaine such to the point where the rats overdosed and died.
Mm-hmm.
And they said, well, given the choice, rats will overdose and die on cocaine. And so, given the choice, humans will overdose and die on cocaine. That was very interesting. They repeated the study about 15 years later. And instead, this time they said, look, we're going to give the rats cocaine water choice or regular water choice, but we're going to make the cage a little bit bigger. And we're going to put some toys in there for these rats. And we're going to have other rats that they can play with. And we're going to have other rats in there that they can have sex with and they can interact with. It was an enriched environment. And they found out that none of those rats died from cocaine overuse. And what that tells you is that when you're lonely and you're isolated, you go to the cocaine. And when you are not lonely and isolated, you tend to interact with other people. And so what we've done is we've built an enrichment environment to reduce the risk of loneliness. Loneliness is our primary driver of addiction. The same thing is true if you looked at the Vietnam War. We had veterans that were coming back, and based upon the heroin usage rate in Vietnam, we expected 60% of heroin usage in Vietnam War veterans. And we expected them to be using heroin when they came back, 60%. But lo and behold, when they came back, only 3 to 5% were abusing narcotics. That was a dramatic shift. It happened overnight. They didn't go through some major detox event. They didn't go through other things. What happened was they were reintegrated into society. They weren't constantly fearful and anxious, and they were no longer lonely. They had people to talk to. They had people to interact with. And so, I think that the isolation that we have is one of the biggest drivers of addiction. And then if you use specific stimulants that affect dopamine to hardwire that in, which is food derived a lot of times, it makes it worse. And that's how I end up treating pain management, diabetes, obesity, and addiction. And that's how it all intertwines. That's how it all interworks with each other. It's inflammation, loneliness, and dopamine.
That is beautiful. I really appreciate this so much. And I hope that your message will continue to spread and to grow. And this model can be repeated. And it's definitely something that I feel is missing and could create a sustainable model for what we need in our country right now in terms of our health. Really empowering people to take control of their own health, and that's what's needed. And we can't really keep relying on the medical system and the medical model and the current paradigm that we're working with. So thank you.
Sure.
I Yeah, I honor and bow down to what you're doing. It's fantastic. And every little bit counts. I feel like what I can offer is on such a small scale, and I know that it changes lives, and we need to somehow be able to do this on a massive scale. Because, like you said, this is going to bankrupt our country, and it's absolutely 100% preventable. And we can reverse this problem. And it's going to take these communities really reaching out to beyond what you and I can do. So, thank you so much for sharing this. It's incredible.
Cool. Thank you.
Yeah. Is there anything else you might want to add to our conversation? If you could, stand on the mountaintop and say, leave people with one thing, what would that be?
So the easiest substitution that we have, the easiest thing that people can substitute is get rid of vegetable oil. I
Yeah.
mean, it's a no-brainer. If you could get rid of vegetable oil, throw your margarine out and use butter. Instead of using vegetable oil, use olive oil. There's no flavor discrepancy. It actually tastes better, and it's a saturated natural fat. If we went back to that, that could possibly eliminate 20 to 30% of fatty liver disease in the United States, and probably 70% of fatty liver disease in East Asia. So that's an easy solution. If we could start there. The rest of it's a little bit harder because we're such sugar addicts, and it takes a little bit more time. But that's the simplest solution, and that's going to make a massive difference. And then back into no sugar, and back into get rid of the grains, get rid of the gluten. Now everybody has a different level of tolerance, but I think that getting rid of the vegetable oil first is where we should start, and getting a supplement of omega-3, like a good krill oil or a good fish oil. If they could do that, that would be a dramatic shift, and it's a low-hanging fruit.
Yeah.
If we could do that, that would be amazing. Other than that, I mean, our protocol is freely available to everybody to use, and it's on our website, reversediabetes.md. And we share it. We don't charge anything. There's no money that we're making at this. We want people to be healthy. So, this has to be guided, because you're going to have some help. And that's why you have to find a medical practitioner to help you, because they will keep you out of trouble. But the protocol's there, and you can educate yourself and pull this off. There's all kinds of additional information on there, but that's where to start. And it would be amazing if people started there, or started anywhere, but start with the simple stuff.
I agree. Take one step, one baby step, and
Exactly.
and just that. So in addition to what you said, I couldn't agree more that that's such a wonderful place for people to start. And with that, what I want to just add is that what that actually looks like when you're moving around out in the world is to just simply stop eating fried food. Okay. So replacing your vegetable oils at home with butter or ghee or coconut oil or olive oil. That's fantastic. And then avoid and stop eating the deep fried food, which is so rampant in virtually every restaurant in my community. So that's kind of what it looks like in the world is where this stuff shows up, where you might not even realize that you're over consuming these vegetable oils that are so high in the omega-6s. So thank you for bringing that up.
Yeah. I mean, just one piece of something that I didn't realize is that in the average Chinese food serving that you get in the average Chinese restaurant, you're getting a half a cup of vegetable oil
Yeah.
in the average serving, and it may not even be fried.
Yeah.
It's added in,
I know.
and
Yeah.
so a lot of the dressings that people use for salad, it's not fried. It's vegetable oil because it's cheap, and
Yep.
even if it looks green, it's just tinged green. It's tinged
Yep.
to look like olive oil, but it's vegetable oil.
Yeah.
So
One of the things I tell all my clients is always have a bottle of olive oil in your purse or your bag or your backpack or your car, and never use anything from a restaurant on your food if it's an oil, because I can guarantee you 99% of the time it is not olive oil, even though it looks like olive oil on the table for your salad. It's not. So, and you're right, it's because it's cheaper. They're using canola oils and corn oils and soybean and everything else. So these are processed, fractionated, many of them oils and even MCT, frankly, I'm not a fan of it. So if you're fractionating or splitting molecules to make an oil, it's not for human consumption. And so, yeah, thank you for just kind of giving us a starting point. I think that's really important. Uh, so is there, we have a few more minutes, but I want to just ask you, is there anything that I can do to support you in what you're doing, or
um,
any of
you
the listeners
know,
for that matter?
the only thing that I ask is that, if people want to follow us on Instagram, I'm there every once in a while. I'm not there consistently. Reverse Diabetes MD. But other than that, I mean, the biggest thing that people can do to support is to help other people. I always look at people and say, look, I helped you change. Who are you helping change? How many people are around you that you can change? Because
Mhm.
if you can do that, it's less likely that this person's going to go backwards. Because the biggest sabotage in the family is the family of the person that you just changed. Because
Absolutely.
they may do well for a year or two, but 3 Christmases from now, they're going to get sabotaged. And the only way that that changes is if you change the entire cell, and you have to change the center core, and you have to change the cell around it. And so I encourage people to change the people around them.
Mm,
And that's so, share what you can with everyone and get them to change. It's the biggest impact you can make,
absolutely.
because it's this is a low cost, high yield approach.
Mhm.
Insulin costs us $800 to $1,200 a month, and that's ridiculous. And the reason why they wait till you have a hemoglobin A1C of 6.5 to start you on insulin is because it's much more difficult to get you off of insulin once you're above 6.5. And so metformin is cheap, and metformin costs 10 cents a day. And that's what we use from hemoglobin A1C 5.7 to 6.5.
Mm,
Most physicians will not prescribe metformin, and because it's been derided by the insulin companies.
mhm.
So my feeling is, there's a financial incentive for these companies to keep people on insulin for a long period of time because it's a revenue stream for them. I think we can reverse that, but
Yeah.
we have to reverse it as a society. And
Ab-
it has to be a groundswell from bottom up, because the drug companies and the food companies are not wanting this.
right. All big change has to come from the ground up. Is
Exactly.
you can see. So is this something, I know that you're dealing with pretty acute situations. Is there a time in somebody's process of recovery or reversal where you can actually begin to add in some carbohydrates later on?
Yeah, we do. Typically, we wait until they've started to reverse, and we add in some carbohydrates. But again, we're not doing 100 grams of carbohydrate. And there's a rational basis for this.
Hmm.
Your liver can only hold 500 grams of glycogen at any given time. Anything above 500 grams overflows. Most people do not decrease their liver glycogen reserve because they don't do enough activity. So they're constantly living at a full glycogen reserve. And so once they get to intermittent fasting phase, where they actually cycle their glycogen down, that's when we start adding unrefined carbohydrate.
Right.
And we typically will use 25 to 50 grams a day. And we're still trying to maintain a very low carbohydrate diet.
Mhm.
But I recognize, and I mean, I love sweet things too. I
Mhm.
eat chocolate and I eat other things, and I try to not have refined carbohydrates at all. But I like a sweet potato, and so I think it's reasonable if that's not what you do every day, and
Yes.
that you have that excursion of glycogen out of your liver. You have to deplete some glycogen out of your liver, otherwise you're in trouble.
Yeah, absolutely. I 100% agree with everything you just said. So thank you for validating that. There's not very many people who have worked with a ketogenic diet or long-term ketosis or low carb diet in general out there to be able to give some of the more long-term feedback that I'm interested in, because it's been a long process for me, and I'm now working with people that are just in a maintenance mode, and I've found the same thing to be true, that you need to practice the intermittent fasting and always adding in the whole foods, slow carbs, real food, and always trying to steer clear of the processed carbohydrates and obviously sugars and things like that, refined sugars. So yeah, thank you. I appreciate that.
Sure.
Yeah. Well, is there anything else you might want to add or say at this point before we part ways?
No, I think this is good. Thank
Okay,
you.
wonderful. Well, thank you so much for coming and speaking. It's been a great honor for me to meet you this way, and I hope that we will stay in touch. I'm definitely going to keep following what you're doing, and I think that it's just such a beautiful offering to the world. Thank you so much for joining me today, and everybody for listening. Thank you again for listening to the Ketogenic Diet Show. You can find me at ketogenicdietcoach.com.